Brain mets workup, do an H&P imaging. Obviously, you want an MRI of the brain. If they have a new cancer diagnosis, you want systemic imaging and a biopsy to determine the primary. If new brain mets diagnosis and solitary, then biopsy. If you have suspected leptomeningeal disease, you also want an MRI spine and a CSF in patient with symptoms, but a negative MRI. You start steroids for symptoms. You start with Decadron, which is dexamethasone, 10 milligrams loading dose, and then 4 milligrams every 6 hours. Give with omeprazole or another PPI for GI prophylaxis. All in all, the volume is more important to overall survival than the actual number of brain metastases. Staging, recursive partitioning analysis class. Stage 1 is good. KPS of 70 or greater and age less than 65 with extracranial disease that is controlled. Brain mets only. This has a survival of about 7 months. 2 is all others, and then 3 is KPS less than 70. GPA has 0, 0.5, or 1 point. For each risk factor, it's site-specific. It varies by diagnosis for breast, lung, etc. It takes into effect KPS, age, extracranial mets, number of brain mets, etc. The post-op dosing per MD Anderson randomized trial for SRS target is the surgical cavity plus 1 millimeter margin. If you have less than 10 cc's, it's 16 gray. 10 to 15 cc's is 14 gray. Greater than 15 cc's is 12 gray. Post-op dosing is basically teenage to driving age in 2 gray increments. 14, 16, 18. Or sorry, 12, 14, 16. So less than 10 cc, 16, 10 to 15 cc's, 14. Greater than 15 is 12 gray. Intact dosing per Brown randomized post-op. They treat other intact lesions with SRS. Less than 1 centimeter is 24. 1 to 2 centimeters is 22. 2 to 3 centimeters is 20. From RTOG 9005, 3 to 4 centimeters is 15 gray. Management, if you have a solitary brain met, you do surgery plus whole brain for a large tumor-causing mass effect or midline shift, or if the diagnosis is in doubt. You can also do surgery plus SRS, SRS alone, or whole brain plus SRS. Multiple mets, so 2 to 4, you can do SRS alone, whole brain plus SRS, or whole brain alone. Multiple mets that are more than 4 or poor KPS, whole brain RT. Leptomeningeal disease, you can do radiation to bulkier symptomatic sites, and if the patient has good performance status and low tumor volume with few symptoms, intrathecal chemo. Consider systemic therapy alone if the patient is asymptomatic. Ipi-Nivo in melanoma that is asymptomatic with less than 2 brain mets. It's a 26% complete response rate. Lapatinib for HER2-positive breast cancer, and erlotinib if lung with mutation. Evidence, Patchell 1, 1990. Both arms had whole brain, only one had surgery. Recall that Patchell was a brain surgeon, so obviously his first research question is going to be, what's the benefit of surgery? So both patients get whole brain, but one gets surgery and another does not. One brain met, again, whole brain versus surgery, plus whole brain, to 36 gray. Increased overall survival when surgery is added to whole brain radiation from 15 to 40 weeks. That's quite a bit of a difference. 11% of the lesions were not metastatic cancer on this trial. Then he followed it up with Patchell 2. Both arms in this case had surgery, only one had whole brain radiation. So he's flipping the question now, okay? What happens if we just do surgery versus surgery and whole brain? Keeping radiation decreases brain recurrence, 70% versus 20%, but there's no difference in overall survival. So there is an overall survival benefit to adding surgery, but not a difference in overall survival to not doing radiation. RTOG 9508, Andrews, Lancet Oncology, 1 to 3 brain mets. They either got whole brain, 37.5, versus whole brain plus an SRS boost. There was an improvement in local control from 70 to 80%, and an improvement in overall survival for solitary mets from 4.9 months to 6.5 months. You can use this trial, RTOG 9508, to defend SRS after whole brain for 1 brain met. The next set of studies look at SRS versus whole brain plus SRS, Aoyama. There was no overall survival benefit to adding whole brain radiation to SRS for 1 to 4 brain mets. However, it does decrease brain recurrence with whole brain radiation. MRI every 3 months. Chang, MD Anderson, Lancet Oncology, 1 to 3 brain mets. Improvement in overall survival, 15 versus 6 months with SRS alone, but worse cognitive function with whole brain. EORTC, Coker, JCO 2011, 1 to 3 brain mets, surgery versus SRS plus or minus whole brain, no difference in overall survival. And then the Alliance study by Brown, JAMA 2016, whole brain radiation is better local control and intracranial control, worse cognition, overall survival the same. After SRS or surgery, doing whole brain improves local control and decreases neurologic death, but there's no overall survival benefit. Anita Mahajan's trial looked at SRS to post-op cavity versus observation. These patients had 1 to 3 brain mets and a gross total resection of at least 1 lesion. 62% of these patients had a single met. The resection cavity had to be 4 centimeters or less, and all unresected lesions 3 centimeters or less. The other got SRS to the cavity or observation to the cavity. Unresected lesion was treated with SRS on both arms. Dose was 16 gray for less than 10 centimeters, 14 for 10 to 15 centimeters, and 12 gray for greater than 15 centimeters cubed. The results here were that local control improves with SRS over observation. The 12-month cavity local control was 72% with SRS versus 43% without, aka 57% recur with OBS and only 28% with SRS. The median overall survival was 17 months, was not different. There was no radiation necrosis with SRS. Larger tumor size was associated with local recurrence. After whole brain, SRS, or surgery improves overall survival in patients with 1 MET or maybe non-small cell RPA class 1. SRS improves Kronosky performance status and decreases the need for steroids. NRG CC001, whole brain plus memantine with or without hippocampal sparing. Hippocampal sparing whole brain improves neurocognitive function. Technique, whole brain dose is either 30 gray and 10 or 37.5 and 15 with memantine for good performance status, KPS greater than 70, and stable systemic disease. Memantine dosing, treatment for 6 months, 5 milligrams in week 1, 10 milligrams week 2, 15 milligrams week 3, 20 milligrams week 4. Check a CNP weekly. SRS dosing per RTOG 9005. GTV is the CTV. PTV is CTV plus 1 millimeter or 2 millimeters of post-op. For less than or equal to 2 centimeters, your dose is 24 gray. For 2 to 3 centimeters, it's 18. And for basically slightly over 3 to 4, it's 15 gray. Stereotactic fractionation, you can either do 8 gray times 3 or 6 gray times 5 for larger tumors and beds. See post-op consensus guidelines, Solomon, IJROPP 2018. Gamma knife script, place the frame, do double gadolinium MRI, contour the GTV and OIRs, do a 1 millimeter expansion on the tumor. You can use multiple isocenters. Normalize to the isodose line best covering, usually 50% isodose line. The conformality index is the planning isodose volume divided by the tumor volume. 1 is perfect, higher is worse. Conformality index should be less than 2 for radiosurgery. Note, hippocampal avoidance studied in RTOG 0933 phase 2, improved memory and quality of life with less than 5% risk of relapse. For constraints, please see above. Toxicity and follow-up, no treatment, 1 month, steroids alone, follow-up in 2 months. Steroids plus whole brain, follow-up in 4 to 7 months. RPA 1, 7 months. RPA 2, 4 months. RPA 3, 2 months. SRS alone, local control, less than 2 centimeters has greater than 90%. 2 to 3 centimeters, 80 to 90%. 3 to 4 centimeters, 60 to 70%. Approximately 50% new brain mets after SRS alone. Acute toxicity include headache, nausea, vomiting, fatigue, hair loss, sore throat, skin irritation. Late toxicity is radiation necrosis, cognition, and memory issues. Question of recurrence versus radiation necrosis. Look at MR SPECT or dual phase PET brain. Necrosis rate post-SRS is 20 to 30%, 5 to 10% of which are symptomatic. In-service exam says 5% rate of radionecrosis with SRS alone based on Brown. Treatment, asymptomatic, you observe. If it's symptomatic, you treat with dexamethasone, 4 milligrams BID times 4 to 6 weeks, then taper and redo your MRI. You could also treat with Avastin, 7.5 milligrams per kilogram every 3 weeks times 2 weeks. It's a durable, high rate of clinical radiographic response. Hyperbaric oxygen or surgery. This can be diagnostic and therapeutic, but high complication rates. Follow-up for whole brain, MRI every 3 months. For SRS, MRI every 2 months. SRS after surgical resection, 80% local control, but salvage whole brain is often needed in 30 to 40% of the time. This is looking at our ongoing RTOG study dose of 15 to 16 gray. For spine mets, workup, get an MRI, CT, and L spine. Start steroids for pain or cord compression and neurosurgical consult. Management, surgery followed by post-op radiation. Definitive RT, EBRT versus SBRT. If fracture, spinal instability, vertebroplasty followed by radiation. Technique and planning, external beam is 30 and 10. SBRT is 30 and 5, 27 and 3, or 18 and 1. Constraints depend on dose and fractionation. Brainstem mets, 14 to 15, gray times 1. If small, less than 1.5 centimeters, or 25 gray and 5. Suprasellar mass, this is the optic chiasm. Here's the tumor. Pineal mass is located here. So you can see it's farther back near the corpus callosum. This is suprasellar, this is pineal. There's the pineal gland. This is whole ventricle radiation. Thecal sac termination at S1. It's right here. This is arteriovenous malformation. This is T1 pre-contrast. This is T1 post-contrast. This is a T2 image. This is the flare. So you have the CSF is bright, and then that gets deleted. T1 pre, T1 post, T2, flare. The optic apparatus is the most sensitive of the cranial nerves. For pituitary adenomas, the optic apparatus must often be shielded. The figure on the left depicts the 8 gray isodose line. The green line contacting the optic nerve outlined in blue. The dose plan on the right shows the 8 gray line no longer contacting the optic nerve. The tumor coverage, the yellow isodose line, remains unchanged. Shielding was achieved by blocking one sector of a nearby gamma knife isocenter. Trigeminal neuralgia, the trigeminal nerve crossing the petrous ridge. This is the cavernous sinus, optic chiasm, third ventricle, internal carotid, 3, 4, 5, 1 and 2, subarachnoid space, 6. Frontal lobe, parietal lobe, occipital lobe, septum pellucidum, rostrum of the corpus callosum, body of the corpus callosum, splenium of the corpus callosum, pituitary gland, sphenoid air sinus, nasopharynx, frontal air sinus, pons, medulla oblongata, cerebrum is 12, cerebellum, spinal cord, fourth ventricle is 14, sinus confluence is 15. 1 is the lateral ventricle, 2 is the third ventricle, 3 is the caudate nucleus, 4, A, anterior limb of the internal capsule, 4B, genu of the internal capsule, 4C, posterior limb. So there's an anterior genu and posterior limb of the internal capsule, caudate nucleus. 5 is the lentiform nucleus, so this is your ice cream cone. Caudate nucleus is the head, which is why it's caudate. 6 is your insula. 7 is the insular artery, which is hard to see. 8 is your thalamus. 9A, gray matter. 9B, white matter. Frontal lobe, parietal lobe, occipital lobe, cerebrum, medulla oblongata, pons, broca area, reading comprehension.